I want to introduce our first speaker, who is Dr. Adam Gaffney, who is the previous president of PNHP. He's actually the immediate past president is a better way to phrase it. But he is a pulmonary and critical care specialist at Cambridge Health Alliance and a assistant professor at Harvard Medical School. He was also co-chair of the working group on single-payer program design, which developed the physician's proposal for a single-payer healthcare reform that was published in the American Journal of Public Health in 2016. He wrote a book, Heal Humankind, The Right to Health in History, which was published in 2017. Dr. Gaffney is well known for his commentary. He has written multiple articles, letters to the editor, and op-eds, and he is well respected in the field of critical care medicine at Harvard. I grant you the floor now, Dr. Gaffney, and we're looking forward to your plenary update here.
Well, thank you so much for that introduction, Susan. Good morning, everyone. It is really wonderful seeing so many familiar faces again and being back in person at the Physicians for a National Health Program National Conference, a time and a conference that has been so meaningful to me and that has really shaped who I am and how I see the world today. But without further ado, I'm going to jump into this year's data update, or at least part of it. In sort of time-honored PNHP tradition for the data update, I will be going through a lot of slides quickly, but they will be available to members afterwards. So let's dive right in. Health. So obviously we are currently facing a fairly catastrophic situation in terms of the health of the United States. Life expectancy has declined dramatically, of course, during the pandemic, as everyone knows. But if you look to the far edge of this graph, which shows life expectancy at birth in the United States from 1960 to 2021, what you'll see is that even before the pandemic struck, gains in life expectancy had plateaued and in some cases actually fallen in that decade prior to the pandemic. Now, the loss of life expectancy during the pandemic, as we all know, has not been equal. On average, we've lost 2.7 years of life expectancy between 2019 to 2021, but the losses in life expectancy were far larger for minority groups, 4 years for Black people, 4 years for Hispanic people, and a catastrophic 7 years almost for American Indian and Alaskan Natives. But focusing only on the death toll of the pandemic does not capture the whole problem, because as I said, our health pre-pandemic was far behind that of other wealthy nations. This is work that came out this year by epidemiologist Jacob Bourne. And he basically, and colleagues, looked at, well, how many Americans would be alive today if we had the same health as other high-income nations? And he called the difference the missing Americans, people who should be alive if we had similar health as other wealthy nations. And before the pandemic, he and colleagues found more than 600,000 missing Americans, and that rose to 1.1 million missing Americans in 2021. Now, the reason for that is clearly not insufficient spending on healthcare. National health expenditures rose. They've been rising, of course. They rose by a huge amount during the 2021, by $365 billion. This is total national health spending, hitting $4.1 trillion in 2020. Now, needless to say, a lot of that was important. There was a lot of increased public health spending. There was increased spending on Medicaid to cover people who lost their job-based insurance. But what didn't get much remarked upon in the news and the coverage of this story was the fact that rising administrative costs contributed to this increase in health spending in 2020. Spending on the overhead of private health insurance companies, just their overhead, the money they take in from revenues, from premiums that does not get spent on healthcare, rose to $300 billion in 2020, as you can see on this graph. But the point I want to make on this graph as well, this is total private health insurance administration, okay? But the blue part is private health insurance that's publicly sponsored, meaning Medicare Advantage, managed care Medicare, Medicaid. So there's a huge amount of taxpayer-sponsored administrative waste through privatized health insurance, privatized public health insurance, that is. Now, looming large in the background behind these large aggregate trends is the fact that even though our health spending is going up, and even though our health is declining, a rising portion of our total healthcare spending is sponsored by taxpayers. This has been shown before, and I'm currently working, this is work in progress, working on looking at this from a longer time perspective. What percent of total healthcare dollars are publicly financed, are taxpayer financed? It's over 50% if you just look at the raw numbers, but if you account for taxpayer subsidization of the employer the employer-sponsored insurance tax break, if you look at taxpayer-financed private health insurance for public employees, we're talking about 70% of all U.S. healthcare spending currently being taxpayer financed. Yet despite that, we're not actually making healthcare available to everyone. So let's talk a little bit about trends in coverage, access, use, and medical debt. So as I said, healthcare costs are soaring. Most of our healthcare dollars are paid for through taxes. Much of it that goes through private health insurance companies. Despite that, we're not covering everyone. This is uninsurance from 1963 to 2021. And yes, we made big gains, as you can see in the far left of the graph, for Medicare and Medicaid. And yes, we made gains with the Affordable Care Act. You can see in the far right part of the graph in 2010, but we still have 9% of the American public uninsured at any given moment. And obviously far more people who experience uninsurance at some point in their lives, right? Meanwhile, we're seeing continued degradation in the quality of insurance. The portion of workers who have a deductible has risen from about half just 15 years ago to almost 90% nowadays, and most people have a deductible. The dollar value of that deductible is, of course, rising from $300 up to almost $1,600 for single coverage. It's almost double for family coverage, and it's far higher for those who get their insurance through the ACA marketplaces. So uninsurance has leveled off at 9%. Underinsurance seems to be rising. And you know, there's the Commonwealth Fund, a think tank, sort of calculates the proportion of people that are underinsured, which is defined by their out-of-pocket cost, their deductible. Details don't matter for the moment, but what they find is that there's a very significant portion of all American individuals are underinsured. And those who are working class, middle income are underinsured at a much higher rate. So high income people, 400% of the federal poverty level, about 1 in 10 are underinsured, but you're talking 28 to 42% for middle and low income Americans. So many of us are underinsured. But underinsurance can have many different flavors and many different manifestations. We just published this study looking at insulin rationing due to cost in the United States in 2021 using national data. And we found that 1.3 million Americans with diabetes who use insulin say they ration insulin because they can't afford it. You know, 9.6% who skip insulin dosages because they can't afford it. 14% who delay buying insulin due to costs. And you know, this has a grim toll, as we've seen in media reports of people who have died, you know, in their homes because they couldn't afford insulin. But it's not just about medication costs. And I should say, you know, for this slideshow, I've really focused just on data in the last year or data that I've updated. So this shouldn't be any old slides you've seen from me before. But so that's why I'm focusing on what I'm focusing on. But just to give an example, when people with diabetes get pushed into high deductible health plans, what happens to their use of care? Previous studies have found that they avoid treatment for cardiovascular conditions. This study this year found that being moved into a high deductible healthcare plan causes people with diabetes to have large delays in seeking care for retinopathy, 0.7-month delay in retinopathy screening, 2.9-month delay in being diagnosed with retinopathy, and nearly a 4-month delay in vision loss, being diagnosed with vision loss and being treated for it. These are the health, we focus a lot on the financial consequences, the financial toxicity of American healthcare. These are examples of health consequences that in many ways are more important. Again, underinsurance comes in many flavors. 19% of privately insured families receive a potential surprise medical bill after delivering a child. The amount of that bill can, you know, for instance, a C-section is on average $5,000. Underinsurance, again, can have many flavors and manifestations. Hospitals suing patients for medical bills, right? A major problem. We don't really have great national figures on this, but in Wisconsin, we know that the number of hospital lawsuits against patients for unpaid medical bills rose from 1.1 per 1,000 residents of Wisconsin to 1.5 per 1,000 residents of Wisconsin over a 20-year period. These lawsuits are not necessarily for large amounts of money on average. Oftentimes they're for small amounts of money, which speaks to the financial constraints of these families. In 52% of the cases, these lawsuits called for wage garnishment, meaning that the patient's future wages would be garnished to pay back the hospital medical bills. There's been a lot of reporting on this from more of a personal perspective of those affected. And there's been really heartbreaking stories of people basically ruined, taken to bankruptcy court, foreclosures on homes, liens on homes, and so forth due to lawsuits from providers. Again, underinsurance has different flavors. The amount of time we get to see a doctor every year, in large part depends upon our background. We published this study this year looking at the amount of time that people spend with a physician face-to-face every year based on their race. And we found that on average, and this is across the whole year, not just one visit, across the year, on average, white patients spend 70 minutes with a doctor a year versus a little more than 50 among Black and Hispanic people. And this is probably due to many things. It's probably due to higher uninsurance rates among those groups, higher underinsurance rates among those groups, racism in the healthcare system, exclusion, geographical access to providers, other factors. But it's a real problem. And again, it speaks to the persistent inequities of our healthcare system. Again, underinsurance can have different manifestations. It can involve being restricted or excluded from particular healthcare providers, right? Narrow networks that basically say you can go here, but you can't go there. And we're going to hear about this in the second part of the talk that Donald will be doing. But this is just looking at Medicare Advantage versus traditional Medicare. Medicare Advantage creates these restrictions, these networks. And as a result, if you have Medicare Advantage, you're less likely to go to a sort of elite cancer hospital for a complex cancer surgery. So 35% of people with traditional Medicare got a Whipple procedure who needed it performed at a sort of elite cancer hospital versus 20% of those with Medicare Advantage. Again, it's an inequity, and it stems from how we finance healthcare in America. I'm not going to dwell on this slide too much. It's a complicated slide, and it could probably be improved upon, but it makes an important point. This study looked at a sort of quasi-experimental phenomenon where people were kind of randomly placed into different Medicare Advantage plans. The basis for that doesn't matter too much. The point is that what this study found was that people who got sort of basically randomly placed in more generous plans, meaning ones that denied less care, had lower mortality. What does that mean? That means that Medicare Advantage plans whose business sort of model to a large extent is denying care or creating barriers to care could very well be worsening health and even increasing mortality. Again, underinsurance has many flavors. Okay, we could obviously talk about that for a long time, but I want to move on. I started talking about the death toll of the COVID pandemic. We know that's due to many different factors, but an important factor, not the biggest one, an important factor is the US medical care system. So I wanted to speak a little bit about how does our medical care system interact with the pandemic and worsen its impacts. So, one very easy way to look at this is simply the return of financial toxicity to COVID care, right? So when the pandemic started, there were emergency measures in place to help people, insurers for a little bit got rid of deductibles if you were hospitalized for COVID-19. That's all gone away. Okay. So right now, if you have cost sharing and you get hospitalized for COVID-19, average out-of-pocket costs are $4,000 for the privately insured, $1,600 for those with Medicare Advantage. So we're seeing the sort of usual operating procedures of American healthcare return to COVID-19 and the way we treat this illness. There were efforts made to make COVID testing free. Insurers had to cover it, but providers were allowed to sell tests sort of for cash as well. So this study found that among urgent care centers in 2020, 84% by August were actually charging patients for PCR testing among urgent care clinics. We did a study just finding that people with who were uninsured were less likely to be tested for COVID and were more likely to test positive. And ongoing work, this is work in progress, suggests that healthcare access does make a difference in terms of who gets vaccinated. Yes, vaccines are free, and that is critically important. But having a routine place of care, having a trusted medical provider, having a trusted primary care physician who can counsel you and advise you and maybe give you the vaccine at the spot at that time makes a difference. So this is work in progress, but we're finding that those who have doctor visits, who have a usual place of care, were more likely to be vaccinated against COVID-19 in 2021. And other work does show that something as simple as receiving a provider recommendation for vaccination increases people's concerns about COVID-19, their confidence in vaccines, and actually their vaccine uptake. So healthcare does matter when it comes to COVID-19. Its inequitable impact is due to far more issues: housing injustice, occupational exposures, all the things that make our society unequal, but healthcare matters. Another way to look at this is the fact that the number of PCPs per capita in a county, as that goes up, the vaccination rate goes up in the county. Okay, so it's just one more way to show why this matters. And another way to sort of look at this is comparing us to other countries. This was a survey done in the US and the UK. And what they did is they asked questions about, have you been vaccinated? Also, do you want to get vaccinated? And in the US, and this is the subgroup who say they're vaccine willing. Okay, this is the subgroup who says they're vaccine willing. In the US, they found that among the vaccine willing, okay, Black people were less likely to have been vaccinated early in 2021. And that pattern did not hold in the UK. So all the focus on vaccine hesitancy and culture wars around vaccines, really gets us off the hook from the medical side, and it gets us off the hook from the perspective of our healthcare system and its inadequacies when it comes to adequate vaccine uptake. And as I said, I think primary care does matter critically here. But the fact of the matter is that we're spending less time each year with a primary care doctor. This is showing trends in the amount of face time with a primary care physician, with specialists from 2005 to 2018. And as you can see, the blue line, primary care, has been going down for the last 15 years. So we're spending less time with the primary care doctor. It's more time with specialists. And that's not going to be very good from the perspective of preventive care uptake. Again, you can look at this a lot of different ways. The use of Paxlovid is very dependent on the wealth of a community. As wealth goes up, Paxlovid administration goes up. And this is all going to get worse, again, as COVID care becomes like everything else in American healthcare. The US government has been buying vaccinations directly from drug companies. This is sort of what we call for in PNHP when we say that we should have national negotiations for drug prices, okay? And whether they're getting the best deal they could or not, we can talk about. But what we know is that now that we're moving towards so-called commercialization of COVID vaccine procurement, and if you've heard, I don't know if you've heard about this, I had an article about this recently. As we move towards commercialization, which is going to mean the government no longer buys the vaccines, and instead private insurers and public insurers buy the vaccine, the cost of those vaccines is going to soar. As we know, Pfizer has said it's going to quadruple the dose. Sorry, not quadruple the dose, quadruple the cost of the COVID vaccine once it goes to the private market, as it will. Maybe they should quadruple the dose as well. I don't know. Not my area. All right. Again, I just want to make the point, this is not all about healthcare. So many other factors play a role. This interesting study came out this year that found that unionized nursing homes had 10.8% lower resident deaths from COVID and 6.8% lower worker infection rate. So issues about worker safety, about worker power, and much more sort of influence the ongoing toll of COVID. All right. I want to talk briefly about reproductive health care. Again, this is a year in review, and I can't review this year without, of course, addressing the really sort of horrifying health decisions of the Supreme Court this year. We saw 4 of them. I mean, the Supreme Court invalidated the COVID-19 worker protection plan of the Occupational Safety and Health Administration back in January. It invalidated state restrictions on handgun carry in the Bourne case. In West Virginia versus EPA, it sort of really undercut the ability of the EPA to regulate carbon emissions. And of course, number 3 here, it overturned Roe v. Wade, eliminating a constitutional right to an abortion. We're already seeing the effects of that. This study just came out this week in JAMA, and it found that as a result of the Dobbs decision, as a result of the overturn of Roe v. Wade, mean travel time to the closest abortion provider in the United States rose from 28 minutes to 100 minutes. The proportion of reproductive age females who live more than 60 minutes from an abortion facility rose 15% to 33%. In some states, the increases are far larger. Average travel time to closest abortion provider in the 2 states with the largest increases, Texas and Louisiana, 7-hour increase to the 7-hour driving time increase to the closest abortion provider. And we know from previous studies, and we know from common sense, that this just means that people will not get abortions who don't want to carry pregnancies to term. As the distance to the closest abortion provider increases, previous study shows that getting an abortion falls in lockstep. The other really critical and frightening health ramifications to be talked about, and this is by no means comprehensive, I just want to touch on a couple highlights, is changing obstetrical management in states with abortion bans as a result of Dobbs. And you've seen a lot of really horrifying news reports, particularly about women or pregnant individuals with pre-viable premature rupture of membranes. This is a situation where typically individuals will be offered the option of an elective termination or expected management. And in many of these cases, these individuals are being denied the option of a termination and suffering significant health consequences, sepsis, infections and other morbidities. And actually a study that came out this year looked at this phenomenon in Texas after their 6-week abortion ban and basically found that, first off, the hospital went from offering, that some proportion of these individuals with pre-viable pre-prom were being offered elective terminations. After the ban, 0% were, 100% were being sort of treated with expectant management, sort of wait and see. And they found very high morbidity among these individuals. 36% developed chorioamnionitis, 4% went to the ICU, 57% had some sort of morbidity associated with this condition. And you'll see there's a lot of news reports about this issue ongoing. And it's going to keep happening. And it's not the only condition. Obviously, there's ectopic pregnancies, there's pre-viable preeclampsia, and other sorts of pregnancy-related conditions whose management is being changed, and people will die. All right, I'm going to close out by talking about another grim development. Sorry, this is, I think there'll be time later in the day for kind of energizing ourselves towards progress in the future and envisioning a better system. But this is more of just kind of giving some facts that are mostly unfortunately negative. So first, I want to just take a step back and look at sort of long-term trends in the investor ownership of American healthcare facilities. Okay, so this is again some work in progress, but I think it is worth sharing. So hospitals in America. This is looking all the way back from 1923 to 2020. Hospitals in America are mostly owned by nonprofit entities. They have always been effectively. We'll talk about a little bit some of the what that means, but I will say that despite that, for-profit ownership of hospitals, and you can see that's the orange line, has been on the rise from the 1970s. So there is an increasing share of US hospitals that are owned by investors, corporate chains. Okay. This may be a little small for people in the back. I'm just going to mention the major points. The major points are that for other kinds of healthcare facilities, for-profit ownership is rising and is the norm. So top left is nursing homes. They've long been dominated by for-profit chains, but that's even increased in the since the 1990s. An increasing share are corporate owned. Hospices started off as sort of these nonprofit or religious-based, mission-based kind of entities. It's mostly a corporate sector now. So vast majority of hospices, top right, blue line, are for-profit. Bottom left is hemodialysis facilities. Again, when dialysis got started, 1970s, it's very small on the far left. Most were nonprofit. Very quickly, for-profits have taken over, non-for-profits are withering, and for-profits dominate the sector. Bottom right-hand corner, home health agencies. Again, when they kind of first were emerging, mostly not-for-profit or public, actually. Initially, Medicare didn't actually allow participation of for-profit home health agencies, and that changed. And as you can see, nonprofit and public home health agencies are declining, and the for-profit share, the blue line in each graph, is predominant. So an increasing proportion of the healthcare delivery sector is owned by investors today, right? And we spend a lot of time in PNHP focusing on the insurers, and that's a critical part, but we're seeing increasing corporate domination of the delivery sector as well. And then physicians are increasingly employees, right? Which is what you'd expect as healthcare sort of merges and morphs into a sort of mature, capitalist industry, it's what you'd expect. So a declining portion of physicians, blue line, see themselves as self-employed or practice owners, and these increasing proportions see themselves as employees. Now, does ownership matter? And the answer is yes. And there's a huge literature about this over many years. And, you can look at this different ways. For hospitals, just to focus on hospitals for a second, for-profit hospitals are more likely to focus on profitable procedures and less likely to focus to offer non-profitable services, not procedures, services. This was a study that came out recently, and it looked at how much over-provision of low-value care different hospital systems were providing, okay? And so what it found, and it's basically asked, okay, what share of health systems are kind of over-providers of low-value care? Basically, lucrative stuff, it doesn't really help people's health. 65% of investor-owned hospitals, health systems were high over providers of low value care. And then those that had less primary care doctors were also over providers of low value care. All right, and there's other studies that have looked at dialysis chains, have looked at nursing homes, and have found evidence of worse quality at investor-owned facilities. That's not in the last year, so I haven't spent time on it, but the data's out there. But what I want to sort of close on before I turn it over for a really critical focus on Medicare Advantage, what I want to focus on sort of in closing is the increasing consolidation and financialization of healthcare delivery that is going beyond sort of what has been seen previously, because it features the vertical integration of insurers with providers, with pharmacy benefit managers, and with basically every type of healthcare provision. So this is United Health Group, which everyone knows and not loves. We're used to United Healthcare and the fact that they are a giant insurer. So they're the largest insurer in the nation, 26 million privately insured folks, 19 million who have managed care, Medicaid, managed care, Medicare, Medicaid. Optum Incorporated, though, and its Optum Health division is actually now the employer of the largest number of physicians of any sort of health entity. They own 60,000 physicians in the US, and there's about 1 million physicians in the US. So that's what, 6%. So a very large proportion of US physicians, and those physicians take care of 101 patients. It's Optum RX division, a giant mail order pharmacy benefit manager, handles 1.4 billion prescriptions annually. So this is sort of consolidation and integration sort of across sectors. And what is interesting and what's important to realize is that an increasing amount of their revenue is coming again from the taxpayer, right? This is taxpayer financed and corporate, but privatized gains. They're in revenue. So this is the health insurance part of United Health. Their revenue is predominantly coming now, not from private health insurance, but from Medicare Advantage and Managed Care Medicaid. So Medicare Advantage is the orange line there. You can see that their revenue, that's revenue in the y-axis, their revenue is much higher for their sort of publicly subsidized public insurance programs that are privatized than it is for sort of traditional private health insurance. And they're getting into new businesses. They recently bought up a home healthcare agency with 960 locations in 37 states. You can see something similar with CVS Health Corporation. Of course, CVS Pharmacy, we know it. It's brick and mortar pharmacies, almost 10,000 locations. CVS Caremark, of course, is a giant provider of pharmacy benefits and mail order pharmacy, 46 million mail order prescriptions a year. They own Aetna, which is a health insurer that they acquired in 2018, and a giant one at that. And then they have their minute clinics, which are growing, which are urgent care urgent care clinics located in their stores, providing 50 million visits a year. They are also buying up home healthcare agencies. They are also moving into primary care provision and to telehealth. Walgreens is also getting into healthcare provision. They also are buying up home healthcare agencies, 19 million members, 74 provider locations in a recent acquisition for $392 million. Walmart is selling Medicare plans. It's providing primary care through Oak Street Health. It acquired a telehealth company. So this is a really important development, and it really, I think, complicates sort of how we envision changing the healthcare system, because simply changing the payer is going to not be enough when this is what's happening on the delivery side. I'm going to conclude with a final development, which is the entry of private equity into healthcare, sort of hyper-capitalism in healthcare, it might be seen as. So what are private equity firms, and what are they doing in healthcare? So these firms basically pool funds from themselves, typically 2%, from investors, 20 to 30%, and then they leverage debt for the remainder, 70 to 80%, and that allows them to purchase a company. And the arrangement is sometimes referred to as a 2 and 20 arrangement. The PE firm, as I said, the PE firm gets 2% in management fees, and that's very high. I'm not a business guy, but I guess I'm told that's very high management fees. And then they get often 20% profit shares. And then after acquiring these businesses, they often will have the business take on a lot of debt. They may sell assets and then turn those proceeds over to the investors. And it's a very short-term sort of thing. They flip these businesses in 4 to 7 years. And overall, this model incentivizes a lot of risk, because they don't have a lot of money invested themselves, but they can make a lot with their management fees. It incentivizes short-term profit maximization, consolidation, cost cutting, asset stripping, and there's little public oversight. And I'm going to get into an example of one of these cases. But private equity deals in healthcare are really soaring globally. They hit 151 billion last year in private equity investments, and I've seen other figures that are higher. This is an old article, 2018, but it's a good illustration of what happens when private equity gets into healthcare. This is a private equity company that bought a nursing home chain in 2007. 4 years later, after acquiring it and running it, right, it basically sold off all of the real estate of the nursing home to a real estate investment trust, which I'll get to in a second. And that arrangement basically means they sell all the assets and then they rent the nursing homes back, right? That's how it works. That allowed them to shell out $1.3 billion to their investors, but then they had to pay rent. So they were paying $472 million in rent for the nursing homes. And then, so that strapped them for cash. So suddenly they are laying off lots of workers, cost cutting, soaring violations, health violations as quality of care fell, as there wasn't enough nurses to take care of the patients, there wasn't enough aides to take care of the patients, really kind of ghastly care. And then eventually they filed for bankruptcy. These real estate investment trusts, so basically again, they buy up healthcare real estate and then they rent it back to the owner, often a private equity investor. They are owning an increasing portion of healthcare facilities as well, 12% of nursing homes, 3% of hospitals. I just have a few more slides showing that this isn't just about the sort of financial complications. We care about healthcare because we care about health and we care about patients. And that's why those of us who are providers went into the field we did. When PE acquires nursing homes, cost goes up by 3.9%, but also the number of avoidable ED visits of residents goes up 11%. The number of avoidable hospitalizations goes up by 9%. Mortality actually goes up by 10% in one study in nursing homes. PE acquisition of hospital leads to 4.4% less nurses and a 1.8% increase in operating margins. More and more physician practices are being purchased by private equity firms. 8% of dermatologists or dermatology practices are now owned by private equity. And they're encouraged after being purchased to maximize profit. This email went out, according to this article, went out to the doctors of this dermatology practice. Don't forget the August bonus for all patients scheduled in August. That's the easiest money you can make. Get that money, exclamation point. When private equity takes over physician practices, charges go up by 20%. And this is my final slide. And then part of the problem, of course, is that as all this money is being made, it allows all these firms, I'm talking about just private equity, I'm talking about the healthcare industry in general, to put that money back into Washington to keep things the way they are. From 2000 to 2022, inflation adjusted money spent on lobbying by the healthcare industry went up to $714 million. And that's what we're up against, right? That's why this is not an easy struggle. That's why creating a national healthcare system is not easy and why we have a big fight ahead of us. So I'll leave it at that. And I think Susan's going to introduce our next speaker.
Thank you, Adam. That was phenomenal. And in the words of Brian Stevenson, a great public health person, if you're not angry, you're not paying attention. I'd like to now introduce Donald Bourne, who was an MD PhD student in health service research and policy at the University of Pittsburgh. And he is a member of the SNAP, Students for National Health Program, our SNAP chapter here. He's worked as a research associate in the Veterans Affairs Evidence Synthesis Program, and he holds an MPH in epidemiology from Oregon Health and Science University. Donald?
Okay, so like Susan said, my name is Donald Bourne, and I'm going to be talking about Medicare privatization, mostly looking at Medicare Advantage, and then the new advent of ACO REACH, which you might know less about. So Medicare Advantage, is privatization of our traditional Medicare program. And these are the main companies that have been in it for the last 20 plus years. And it continues to grow every single year. If trends hold, by next year, more than half of Medicare recipients are going to be on some type of private plan. And this is projected to keep growing. Yeah, so it's going to, over the next 10 years, just keep getting higher and higher. And a major part of Medicare Advantage programs' profit strategy has been upcoding. And this is something that's been reported in the academic literature for over a decade now. but now mainstream media is starting to pay attention. I'm sure a lot of you guys probably saw this New York Times article that came out recently that was looking at what they called the cash monster. And so we'll go over some of what they found. So this is the list of the top companies in Medicare Advantage that have either been charged with fraud or convicted of fraud by the federal government in their plans. One such plan on this list is Cigna. And so just to give some numbers, in 2021, they paid over $97 million to settle allegations of duplicate and inflated claims submitted to the Department of Veterans Affairs while it was acting as a third-party administrator for the program. And their benefits manager portion of their business has paid $260 million in fines related to overcharging state Medicaid programs for prescription drugs. And it's not just, administration and drug costs being overcharged and stuff. It's also these insurers paying doctors and nurses more for recording additional diagnoses so that they can upcode these. And then also putting in invalid diagnoses and not removing them because it makes them money to have more diagnoses for a patient. And then at least two insurers on this list, Kaiser and Cigna, they've been accused of discouraging care for new diagnoses, which, is pretty abhorrent if you think about it. And this is a huge number. It's estimated that overbilling is between 12 and 25 billion. That's more than the entire budget of some really big federal agencies like NASA, FBI, EPA, the entire federal prison system. And last year, the Justice Department's Civil Division listed Medicare Advantage is one of the top areas of fraud recovery. So they are, recouping a lot of dollars, but not anywhere near 12 to 25 billion. And right now, the Justice Department has either brought or joined 12 of the 21 cases that have made public. But a lot of these cases are brought up by whistleblowers, and those are usually secret until the department evaluates them and decides to join them or not for whistleblower protection. And so why is it called the money machine? Well, if we look at Medicare Advantage, compare it to the individual market and compare it to the group market, the margins are just so much higher for Medicare Advantage. And remember, this is all taxpayer dollar that's flowing through Medicare Advantage. So for insurers that already dominate the healthcare market, Medicare Advantage has been insanely profitable. Yeah, it's about twice as much as gross profit compared to other insurance plans. And so we got to think to ourselves, okay, we're spending all of this money, more than traditional Medicare. What are patients and the federal government getting in return? And so from a recent systematic review comparing Medicare Advantage to traditional Medicare, we found that taxpayers are paying 5% more. They're paying 105% of what a traditional Medicare beneficiary would cost. However, evidence on patient experience, readmission rates, mortality, racial and ethnic disparities, and in other health outcomes didn't show a trend of better performance and were in many cases worse under Medicare Advantage. And the Office of Inspector General has even released a report stating that Medicare Advantage plans are often denying needed care that would have been covered under the traditional Medicare program or was supposed to be covered, but unjustly denied under Medicare Advantage. And so now the other half of the issue with privatization of Medicare is ACO REACH. So the one thing about Medicare Advantage is that people know it's private healthcare, and seniors get a choice whether to choose traditional Medicare or select one of the Medicare Advantage plans available to them. However, under the Trump administration, direct contracting entities came into play. Now, PNHP made a really big push against them, and I'll go over the timeline in a couple slides. But under the Biden administration, that has been transformed into what's called ACO REACH. And these are basically new risk-bearing entities that insert themselves in between traditional Medicare and doctors and patients. And the big issue around this is that patients don't get a choice. These sign up for traditional Medicare, but depending upon their doctor, depending upon where they live, they could be put into one of these ACO REACH programs. And so this is a little bit what I said already, but this is basically done under CMMI, Centers for Medicare and Medicaid Innovation, is a pilot program. And CMMI has the authority through the Affordable Care Act to institute these pilot programs if HHS, Health and Human Services, believes that it could reduce spending without decreasing quality or improve quality without increasing spending. And it can't deny or limit coverage of provision of benefits like Medicare Advantage can. But as we've seen with other things, just because an insurance company is not supposed to do something doesn't mean that they don't. So this slide, I want to take a sec to thank the PNHP staff that worked on it. It's a year old now, so it doesn't include the new ACO REACH people, but a lot of the direct contracting entities, DCEs, are in the ACO REACH program. So it's probably still the same proportion. So it includes a mix of ACOs, PCP groups, and specialty providers, but that's the minority. Most of them are going to be run by either publicly traded or publicly backed private equity and venture capital firms. And most of them are owned by some of the largest insurers in the country. I tried to update this for 2022, but this is extremely difficult because so many of the DCE and ACO REACH providers are LLCs. And so it's really hard to know, which LLCs, Cigna or United Health and stuff own, because there's just so many of them. But a preliminary review of this by PNHP identified at least 10 participating organizations that have histories of defrauding Medicare in other government programs. And some of those were highlighted in that New York Times article. And so here's the timeline. So back in early 2019, HHS announced the global and professional direct contracting model, and it began in early 2021. And by November that year, PNHP President Susan Rogers led a delegation of doctors to lead a petition of with over 13,000 signatures directly to HHS demanding an end to the program. And that, I'm sure, led to the Jayapal letter earlier in 2022 that was signed by a large proportion of Congress and called for the end of the model as well. And then a month later, Dr. Susan Rogers was able to testify and give some pretty strong testimony in front of the US Senate, and calling out the dangers of direct contracting. Unfortunately, it didn't kill the program. It just led to this transformation. And I'll kind of go over what has changed in the program. So this is a lot of information. You can probably barely read it, but it's more of a data dump because the slides will be available later. And in the next few slides, I'll kind of highlight the main differences between direct contracting and ACO REACH. One thing to point out here is the say equity and ACO REACH 8 times on here, and I'll go over what they mean by equity. So the ACO REACH model, there's 2 main revenue streams. One is capitation and the other is financial risk. So capitation, it can be limited to primary care or extend to total care, depending upon the model that the REACH entity chooses. And so it pays for care within its REACH network, and then CMS pays for care outside of the REACH network. And then how the financial risk portion works is that under the professional model, the REACH bears 50% of shared savings and losses, and that in the global model, it would bear 100% of savings or losses. However, if you analyze that crazy slide that I showed, you'll see that CMS is really only changing the name. Profiting from reduced care is still occurring. There's actually less focus on quality of care, and that risk adjustment manipulation is still there. The risk adjustment manipulation is very similar incentives to what's under Medicare Advantage. And we've seen what happens in regards to that with upcoding. So the profiteering, it's introducing a middleman, and they have an incentive to reduce the amount of care spent on seniors because they get to reap those savings themselves. The medical loss ratio is 40%, which is double the 20% cap put in by the ACA. And so, like I said, there's still that pressure for upcoding. So ACO REACH engages primary care physicians, and then CMS capitates payments to by each patient. And then they maximize that by decreasing provided services and increasing upcoding. And so this is just an example of how risk scores and upcoding works. So for a relatively healthy Medicare beneficiary, CMS might pay a program like Medicare Advantage, or in this case, ACO REACH, like $4,000 a year. But as soon as you start adding things like diabetes, chronic heart failure, asthma, stuff like that, it quickly jumps up. And that's really the incentive for upcoding, whether, you know, that person has enough, data to justify that diagnosis or not, has been questionable. And in order to really maximize the coding for risk factors for patients, insurance companies have pushed doctors to do things like routine screening for carotid ultrasounds, which is not recommended by USPSTF. However, if a patient is positive on that screening, that increases the reimbursement by $2,800 a year. So in some cases, you're over-screening or over-treating a patient in order to reap the profits from upcoding and risk scores. So it's called the ACO REACH. The Affordable Care Act is extremely popular among Americans. And so a lot of people associate ACOs with the Affordable Care Act. It kind of feeds off of that positive press. And it also uses the word equity a lot, which, you know, we all want from a health plan. But as we'll see in these slides, it's really more lip service. So how is it not like other ACOs? Well, ACO REACH retains 100% of the first 25% in drop in spending. Other ACOs, it's much more graduated and evenly split between the ACO and the insurance plan, in this case, Medicare. Every single other ACO has to meet certain quality measures in order to actually retain those savings. ACO REACH does not. As we saw in a couple slides ago, if they get really bad quality scores, the most they can get dinged for is 2%. Well, that means nothing if you can decrease care up to 25% and save all of that savings as profit. It does call for 75% of control of like the governing board to be participating providers and for them to have voting rights. That sounds great. However, there's loopholes where they can say that they're engaging these providers in an equivalent manner, and so they don't have to be on the board and hold voting rights. I have no idea what would be equivalent to being on the board and holding voting rights that isn't that, but somehow there's a form that they can fill out and get around that. And then also requiring them to have at least 2 beneficiary advocates on the board and hold voting rights as well. I don't know if any of you guys have had experience in IRBs and having you know, patient advocates and stuff like that on the board. They're valuable, they're useful. 2 voting members isn't going to make a difference, unfortunately. In this case, control will still remain with the corporate investors and executives. So lip service to health equity. The E in ACO REACH stands for equity. If you look on their webpage, it says equity a million times. It's just like a barf of PR jargon. I really get annoyed with it because, so I'm a health policy researcher and I want to work in the health equity space. So it really frustrates me when someone is using health equity to do the exact opposite. So here's what they say that their health equity requirements include. So one is a health equity plan. That sounds great. Health equity benchmark adjustment. That sounds great. Health equity data collection requirement. That sounds great too. And health equity questions and application and scoring to see if they want to let a plan be part of the ACO REACH model. So let's look at what those things actually are. Here's the last page of the health equity plan requirement. This is the entire plan. The previous 4 pages in the document basically walk someone through how to fill this out. This doesn't look like it would lead to a really robust health equity plan for an entire, you know, insurance plan risk mediary type person. It's lip service. That's all it is. Here's the benchmark adjustment. If you are in the top 10% decile, you get $30 more per beneficiary per month. If you are doing a really bad job on your health equity benchmarks, you get $6 less per beneficiary per month. If we look at the average Medicare beneficiary, you know, what they're going to be paying, the average Medicare beneficiary costs about $15,000 a year, a little bit more. So if they do a really good job, the incentive, that $30 per beneficiary per month, that equates to about 2%. That's not that much. If you do a really, really bad job, it dings you less than 0.5%. Again, that doesn't seem like a real financial motivation for these people when they can reap so much from just reducing the provided services. Data collection requirement for health equity. It's two components: demographic data and social determinants of health. Race, ethnicity, language, gender identity, sexual orientation. We get a bonus for capturing this information. This is already in everyone's medical record for the most part. And if not, it just should be, because it should be. You shouldn't get up to a 10 percentage point bonus in your quality score for recording basic demographic information. The other part is social determinants of health, TBD. They haven't determined what social determinants of health they're going to include. And also, here's the thing, collecting this data does squat to address health disparities. You have to actually do something with that. You actually have to connect people with services to address these social determinants of health. This does nothing to advance that. And then, so lastly, this health equity questionnaire for screening applications. So they say that discrete points are applied to the scoring process based on direct patient care experience and experience furnishing high quality care to underserved communities. However, they make it clear, like it's literally stated that this does not apply to former DCE participants. They can get into the ACO REACH program just by filling out that health equity plan, the little one-pager fill in the blank that I showed you. They don't have to meet any of these really less than bare minimum, really nothing requirements. However, new participants supposedly do. However, we know from the published list of active participants in the program that there's tons of them that have zero patient care experience, no experience in the healthcare field. So lastly, even though this is a pilot, CMS isn't waiting for this data. They've made it really clear that their goal is for every single Medicare beneficiary to be in a plan like this by 2030. And unfortunately, if that happens, that would lead to the full privatization of Medicare, our public good. It would violate the spirit of it being a public health program, and it would corrode the value of it as well, expanding opportunities for profiteering. And it really jeopardizes our fight for Medicare for all. So thank you.